Good day, I am Giwa Winifred Damlola, a 500 level student of the Faculty of Pharmaceutical Sciences, University of Ilorin, and I'll be presenting a case on diabetes mellitus foot syndrome with ocular allergy, breast myopia complicated with diabetic retinopathy. The World Health Organization defines diabetes mellitus foot syndrome as ulceration of the foot associated with neuropathy and different grades of ischemia and infection. It is classified into grade 0 to 5. Grade 0 is said to occur when there is intact skin. Grade 1 is said to occur when there's superficial ulcer. Grade 2 when there is deep ulcer to tendon, bone, or joint. Grade 3 when there is deep ulcer with abscess or osteomyelitis. Grade 4 when there is forefoot gangrene, and grade 5 when there is all foot gangrene. The causes of diabetes mellitus foot syndrome are said to be complex and multifactorial, which includes peripheral neuropathy, foot deformity, abnormal foot pressures, abnormal joint mobility, trauma, peripheral artery disease, etc. The case I'll be considering this afternoon is as a result of loss of sensory sensation due to peripheral neuropathy. According to the American Diabetes Association guideline, which approaches the treatment of diabetes mellitus foot syndrome, Wagner grade 5. It includes offloading of the wound, daily dressing of the wound, debridement when necessary, antibiotic therapy, optimal control of blood glucose, evaluation and correction of peripheral arterial insufficiency, and also amputation. SA is a 53-year-old male who is married. He was brought into the hospital on account of left foot ulcer for 6 weeks with the presence of cracks on his left foot and general body weakness. On examination, he was looking pale with no fever associated, no vomiting, no headache, no cough, no form of breathlessness, and there was no decrease in his urine volume. His CVS values, his pulse rate was 96 beats per minute. His blood pressure was 110 millimeter mercury over 60 millimeter mercury on admission. 160 millimeter mercury over 100 millimeter mercury prior to his antihypertensive drug commencement. 112 millimeter mercury over 72 millimeter mercury as at my last encounter with SA. His fasting blood sugar values, 8.7 millimole per liter on admission, 3.1 millimole per liter prior to his insulin dose adjustment, 4.5 millimole per liter as at my last encounter with SA. His PCV was 32% on admission and 40% on discharge. Assessment: diabetes mellitus foot syndrome, Wagner grade 5, with ocular allergy, breast myopia, complicated with diabetic retinopathy, and was also diagnosed of anemia. His current medications: intravenous metronidazole, which is used for the treatment of bacterial infections, given 500 milligram 8 hourly daily. Intravenous paracetamol and analgesic, given 600 milligram 8 hourly for 3 days. Capsule of vitamin A, an eye antioxidant, given 2,500 IU daily for 2 weeks. Capsule of vitamin E, an antioxidant, given 200 IU daily for 2 weeks. Tablet of vitamin C, given to aid wound healing, 500 milligram 8 hourly for 2 weeks. Tablet of zinc, used to boost his immunity, 40 milligram daily for 2 weeks. Intravenous ceftriaxone, which is used for the treatment of bacterial infection, given 1 gram 12 hourly for 5 days. Subcutaneous enoxaparin, an anticoagulant, given 40 milligram daily. Subcutaneous mixed insulin, given an hypoglycemic agent, given 20 IU in the morning and 10 IU at night daily. Capsule of Astifa and imatinib, which is given 2 capsules 12 hourly daily. Then anti-large eye drop, given for ocular allergy, which is given 1 drop in both eyes daily. Tablet of loratadine, an antihistamine, given 10 milligram daily. Tablet of lisinopril, an antihypertensive agent belonging to the class ACEIs, 5 milligram daily. His past medication history: on admission, SA was given intramuscular tetanus toxoid, which is used for tetanus prophylaxis, 0.5 ml start. It was also given intramuscular ATS, which is used for tetanus prophylaxis, 1,500 IU start. It was given intravenous clindamycin, which is used for treatment of bacterial infection, 600 milligram 8 hourly daily, which was eventually changed to intravenous ceftriaxone. It was also, he took tablet of metformin as his oral hypoglycemic agent, 1 gram 12 hourly daily, and also tablet of glibenclamide, an oral hypoglycemic agent given 2 milligrams daily. He has no history of herbal medication. SA is a married man with children. He is a Muslim trader with no history of smoking or alcohol intake, and he has no known drug allergy. Drug therapy problem: adverse drug reaction, which occurred as a result of concomitant use of ceftriaxone and enoxaparin, which increases the anticoagulant activity of enoxaparin. The care plan: the goal, to prevent complication due to the adverse drug reaction, which is the concomitant use of ceftriaxone and enoxaparin, which increases the anticoagulant effect of enoxaparin. My objective is to maintain a normal international normalized ratio, INR, which is between 1.1 to 3.0. My interventions: I communicated with the drug therapy problem to my receptor. I educated the patient on routine preventive foot care, which includes daily self-inspection of his feet, wearing of appropriate shoes, and avoidance of barefoot walking. And then I also educated the patient on the need for regular monitoring of his blood glucose, drug compliance, and other diabetic complications. Prognosis: SA was discharged with a stable and optimal blood glucose level and blood pressure on the 15th of March 2021 following a successful amputation surgery. He is to report at the hospital in 7 days for redressing. His medications on discharge: capsule of vitamin A given 2,500 IU for 2 weeks, capsule of vitamin E given 200 IU for 2 weeks, tablet of vitamin C given 500 milligram 8 hourly for 2 weeks, tablet of zinc given 40 milligram daily for 2 weeks, subcutaneous mixed insulin given 20 IU in the morning, 10 IU at night daily, capsule of Astifa, an imatinib, which is given 2 capsules 12 hourly daily, anti-large eye drop given 1 drop in both eyes daily, tablet of lisinopril given 5 milligram daily, and tablet of cefuroxime given 500 milligram 12 hourly for 10 days.
My name is Yusuf Abdulmalik, and I will presenting a case of Mrs. EE, who was admitted to this facility on account of recurrent episode of vaginal discharge, fever, and loss of weight. Patient EE is a gravid 3. The objective data on 9th of February 2021, our BP is 110/70. Our pulse rate is 60 beats per minute. Our PCV is 26%. Our sodium is 124 millimole per liter. Our potassium is 3.7 millimole per liter. The urea is 5.3 millimole per liter. The creatinine is 167 millimole per liter. The patient is afebrile, is not dehydrated, is not pale, is chronically ill looking. The LVD test is reactive, and the CD4 is 94 cells per cubic millimeter. On 16th of February 2021, our BP is 120/80, our pulse rate is 125 beats per minute, our PCV is 27%, our sodium is 127 millimole per liter, our potassium is 6.0 millimole per liter, urea is 36.5 millimole per liter, and creatinine is 830 millimole per liter. SpO2 is 84%, and EE also has a bed salt, which yield E. coli and Enterococcus species sensitive to imipenem and unacin, respectively. The assessment is histological diagnosed cancer of the cervix. HIV/AIDS complicated by obstructive nephropathy with decubitus ulcer. Our plan or current medication is tab vitamin B co to stimulate appetite, 2 tablets 3 times daily, open prescription. Tablets nystatin for fungal infection, 500,000 IU BD, open prescription. Tab indapamide for volume overload, 1.5 milligram OD, open prescription. IV paracetamol for pain and fever, 600 milligram BD, open prescription. Tab fesolate for anemia, 400 milligram TDS, open prescription. Syrup aminopep for amino acid deficiency, 150 ml twice daily, open prescription. IV ondansetron for nausea and vomiting, 5 milligram twice daily, open prescription. Tab spironolactone for fluid and volume overload, 50 milligram once daily open prescription. Tab tosemide for fluid and volume overload, 100 milligram once daily open prescription. IM promethazine for nausea and vomiting, 25 milligram as a starting dose open prescription. Liquid paraffin for constipation at a dose of 5 ml open prescription. Tab lisinopril for hypertension, 5 milligram once daily open prescription. And a combination of abacavir, lamivudine, dolutegravir at a dose of 200 milligram, 300 milligram, and 50 milligram respectively for 1 month for HIV/AIDS infection, and cotrimazole for opportunistic infection in HIV/AIDS at a dose of 960 milligram once daily for 1 month. The patient is also scheduled for hemodialysis for the same day and also to be placed on 100% oxygen via nasal ring at the rate of 4 to 6 liters per minute to maintain SpO2 above or equal 95%. Our past medication history include tab bisacodyl for constipation, 5 milligram twice daily, tab vitamin C for immunity, 500 milligram 3 times daily open prescription, tab vitamin A for vitamin A deficiency, 2,500 IU once daily, tab vitamin E for vitamin E deficiency, 200 IU once daily, tab vitamin B complex to boost appetite, 2 tablets twice daily, tab lisinopril 5 milligram for hypertension once daily, tab spironolactone for hypertension 50 milligram once daily, tab indapamide for volume overload 1.5 milligram once daily, tab nystatin for fungal infection 500,000 IU twice daily, tab fesolate for anemia 400 milligram 3 times daily, tab paracetamol for pain and fever 1 gram 3 times daily for 3 days, syrup morphine for pain 2.5 milligram 4 times daily open prescription, IV ondansetron for nausea and vomiting 5 milligram twice daily open prescription, tab ciprofloxacin to prevent infection 500 milligram BD for 5 days, tab metronidazole to prevent infection 500 milligram 3 times daily for 5 days, liquid paraffin for constipation 5 minutes 3 times daily, IM promethazine for nausea and vomiting 25 milligram starts, and a combination of abacavir, lamivudine, dolutegravir at a dose of 600 milligram, 300 milligram, and 50 milligram respectively for 1 month, and cotrimazole for opportunistic infection at a dose of 960 milligram once daily. The other medication or alternative therapy is osimum gratismimum, otherwise known as ephedrine, which patient takes at terminating, and the duration and dose is unknown. The patient also takes a painkiller, but the name of the painkiller is unknown, and it takes anti-malaria regularly whenever you have signs and symptoms of malaria. The social history of this patient: he is a teacher that lives in Goma area of Ilorin, is a Christian, and who deny history of previous smoking or excessive alcohol abuse, and there is no known allergy or any medical allergy or drug allergy or food allergy. The drug therapy problem identified with this patient is adverse drug reaction, and the adverse drug reaction could either be due to interaction between spironolactone and lisinopril, which is an ACI, or as a result of the dose of spironolactone increased too quickly. Because when you administer lisinopril and spironolactone together, there's an increased risk of hyperkalemia, because both of them has hyperkalemia as a major side effect. So a combination of these effects will lead to severe hyperkalemia, and the patient needs to be properly monitored. And the other drug therapy problem identified is inappropriate compliance, because the patient, Mrs. E, find it difficult to swallow the medication at one point in time because there's a lot of medication, and also the patient will not also afford the antibiotic that is recommended based on the sensitivity test to treat the bed sore. So the care plan for this patient: number one is the goal is to withdraw spironolactone till potassium level is within normal range, and to ensure that patient adhere and complies with medication regimen. And the objective of these is to discuss with the nephrologist on the severe hyperkalemic effects of the combination of an ACI and spironolactone in patients with CKD, especially patients with CKD. They have hyperkalemia as one of their side effects. Potassium is not well excreted, and also due to the cells losing their fluid, and there is an extracellular leakage of potassium also. All this contributes to hyperkalemia, and the dose of spironolactone should be withdrawn, or the dose should be reduced. because even in patients with renal patient, those can be reduced as low as 25 milligrams of spironolactone. So, and to treat hyperkalemia, because according to the American Journal of Medicine, if hyperkalemia is potassium level go above 6.5 millimoles per liter, then the hyperkalemia there is a risk of cardiac arrhythmia, and it's become very important to treat hyperkalemia as early as possible. So to counsel the caregiver on the need to get the antibiotics to enhance the rapid healing of the bed sore, as no other alternative is available based on the bacterial, based on the MCL results, and to discuss with the physician on the possible introduction of the nasogastric tube, because this patient has been finding it difficult to swallow the drug and is becoming the level of is becoming unconscious. So there is a need to look for a means to enhance the drug delivery in these patients. So the intervention was discussed. The problem was discussed with our preceptors, who then take their appropriate follow-up. Thank you.
Okay, good day. I'm Adekunle Damola. I'll be presenting a case on chronic kidney disease secondary to hypertensive neuropathy complicated by rheumatoid syndrome. According to the Kidney Disease Outcomes Quality Initiative of the National Kidney Foundation, chronic kidney disease is defined as either kidney damage or a decreased glomerular filtration rate of less than 60 ml per minute per 173 meters square for at least 3 months. And then we have 5 stages of chronic kidney disease. The stage 1, which is kidney damage with normal or decreased GFR, greater than 90 ml per minute per 1.73 meters square. We have the stage 2, which is just mild reduction in GFR as 60 to 89 ml per minute per 1.73 meters square. We have stage 3A, moderate reduction in GFR, that's 45 to 59 ml per minute per 1.73 meters square. We have stage 3B, moderate reduction in GFR, 30 to 44 ml per minute per 1.73 meters square. Then stage 4, severe reduction in GFR, which is 15 to 29 ml per minute per 1.73 meters square. And then the stage 5, which is kidney failure, GFR of less than 15 ml per minute per 1.73 meters square, or we call this the stage where the patient has to go for dialysis. Okay, so the patient case presented to the clinic, to the hospital, with generalized body swelling, breathlessness, insomnia with body pain, and then stomach pain. She, on examination, she's a middle-aged woman, 53 years of age, and conscious. She was conscious. She had breathlessness, as she said. She was pale, no temperature, and she was not dehydrated. At first contact, when her blood pressure was measured, it was 150/90. Her pulse rate was 90 beats per minute, and then her respiratory rate was 25 CPM. Then, on conducting the laboratory investigation, her sodium levels was 124 millimole per liter. Potassium was 6.8 millimole per liter. Urea was 141.5 millimole per liter, and creatinine was 1,828. That's 1,828 millimole per liter, which is very high, as contrary to the standard, which is 50 to 110 millimole per liter. And then our packed cell volume was 18%, which was supposed, and which is actually within limits. So the drug therapy, the current drug therapy plan, she's on, when I met her at the clinic, she was on tizanidine for muscle spasticity, tabsosamide for edema associated with renal failure, ketoprofen gel for pain management, medtriol capsule for electrolyte imbalance, and also to manage hyperparathyroidism and hypocalcemia. Then she was also on tab Cargovite, for electrolyte imbalance and hypocalcemia, that's 500 milligram daily, cap acipa for anemia, 2 capsules BD, then tab indapamide for edema and blood pressure control, 1.5 milligram daily, Then she was also on tab metronidazole for anaerobic infection, 400 milligram TDS. Then she was on tab buscopan for abdominal pain, 10 milligram TDS. She was also on tab GF118 for neck pain, 30 milligram TDS, tab rabeprazole for gastritis, 20 milligram daily, and then she was on paracetamol for analgesia, 1 gram TDS. Okay, so a past medication, when she came into the clinic, she was on torsemide for edema associated with blood pressure, and also she was treated for malaria with Atita injection, and she was given ceftriaxone also, and tramadol and PCM for pain. Now the drug, okay, for history, she's a Christian and a trader, and she said she hasn't been on any herbal medications, and there has been no history of any allergies. So the drug therapy problems. One, the patient is a known hypertensive patient, and it was observed that she was not compliant with her antihypertensive medications, and that was what resulted into the complication of the disease state, causing the CKD, chronic kidney disease, secondary to hypertensive neuropathy. And so currently she was non-adherent to present therapy, and she complained that is carbohydrate. She complained that it's too sweet, and then it causes her to use the toilet often. And also observed some adverse drug reaction between some of the drugs that was prescribed for her. One, torsemide and nidapamide. Both drugs they both decrease serum potassium, and also rabeprazole also causes a limitation in the absorption of ferrous sulfate. And there was also a case of drug unavailability. She wasn't able to use, she couldn't obtain tizanidine and PCM. When she was collected, she said it was because she said they were going to get it, but by the time we made the investigation, we realized it was due to financial constraints. Okay, so the goals of therapy. Okay, so my care plan is to treat the pathologic manifestations, and also to okay, for the care plan, according to the guidelines for treatment of chronic kidney disease based on the Medscape Journal of Medicine, anemia is to be treated with erythropoiesis stimulating agent, and also hyperphosphatemia is to be managed. Hypocalcemia is to be treated with calcium supplements. Hyperparathyroidism is also to be managed with calcitriol. Then the volume overload should be managed with loop diuretics. Then metabolic acidosis should be treated with oral alkali supplementation. The goals of therapy is to inform the other members of the healthcare team to closely monitor the patient potassium levels, to encourage the patient on adherence to prescribed medication, to recommend that the administration of rabeprazole and aspirin ferrous sulfate be spaced appropriately so as to manage the effects that rabeprazole has on the absorption of ferrous sulfate. The objective is to delay the disease progression and to ensure the management of the pathologic manifestations and underlying conditions. So based on guidelines, we've observed that most of the pathologic manifestations are being managed by the drugs that the patient was given. And the intervention, I communicated the drug therapy problems to my preceptor. And then there was communication with the concerned members of the healthcare team on close monitoring of patients' potassium levels. Also, the patient was encouraged to take her drugs as appropriate. She actually remained unyielding on the issue with carbohydrates. She seemed very uncomfortable with the fact that she had to go to the toilet so often. And then she had distributed that to the effect of the drug. So suggested that the carbohydrates should be replaced with Calcimax, 500 milligram daily. That is a drug that is not as sweet as carbohydrate, and that should help the patients in that area. Also, it was recommended that the administration of rabeprazole and aspirin be spaced appropriately so as to prevent the limiting effects that rabeprazole causes on the absorption of aspirin. So it was recommended that the patient should use rabeprazole early in the morning with breakfast, while ferrous sulfate should be taken before lunch and dinner. The patient was referred to the welfare department of the hospital for assistance to aid the acquisition of the drug she was unable to purchase. The patient was also counseled on proper diet intake based on her disease state and encouraged to engage in bodily exercise as much as she can. She was advised to avoid the intakes of food that are high in phosphorus so as to control the level of phosphorus in her body, in her blood system, and also to avoid foods that are high in that are acid producing so as to also manage metabolic acidosis. So she should take more food, more of plant proteins, such as fruits and vegetables, rather than animal proteins, such as chicken meat, and also avoid fast foods and canned foods. The patient is to be followed up on compliance to medication and also should be followed up on regular checkup of our BP, of our blood pressure, so as to avoid further complications. Prognosis: patient was discharged on the 20th of February 2021 after being assessed as stable by the doctor. She had a total of 8 sessions of dialysis, and the drugs given her on discharge are tab-topsemide 100 mg to be used 12 hourly, tab-sadolad 2 mg AM and 4 mg PM, tab-calcitriol 0.25 microgram daily, cap astifa 2 caps 12 hourly, tab indapamide 1.5 mg once daily, tab buscopan 8 mg 8 hourly, tab rabeprazole 20 mg once daily. She was told to visit the hospital again after 2 weeks for assessment. The guidelines consulted at Clinical 2012 Clinical Practice Guidelines for the evaluation of and management of chronic kidney disease, and also the NICE guidelines for the management of chronic kidney disease. Thank you.